So today we're going to be working on pain between blades, pain between the shoulder blades. The likely one is in the side of your neck right here.
No, not that again.
Yeah, that's it again.
This whole idea of pain is where the problem is.
Yeah, that's this muscle right here.
Yeah.
So the scalenes, they cause pain between the shoulder blades, that deep, achy pain. Let's take a look at where that would be. So usually this pain you would feel right there. So with, a lot of times if the scalenes were causing their kind of chronic pain, you'd feel it right there. And if it got worse, you begin to see it in this pattern. And if it got even worse, here. And if it got even worse, it can pull up on these first two ribs. And then it can cause nerve compression, which then you feel down to the little finger side. So you can have pain and nerve compression, and you can have another nerve compression. The posterior scalene, this one right here that attaches onto the second rib, between that and this middle scalene, it can compress another nerve that goes to the side of the chest, the anterior serratus, and that is right here somewhere.
Anterior serratus.
It's one of our muscles we're treating today. And there it is, right here next to us. And here it is right here. It attaches onto the first rib and all the way down to the ninth rib there. And it causes pain right there, and just below. So this one is a little higher, and this one here is a little lower. So between the two, they cover a pretty good area in the back of the shoulder blade, as well as going down the arm, all of them. So sometimes, though, you only feel that pain between the shoulder blades. That never goes away.
And it never goes away in the shoulder blades?
Why? Because it's not from between the shoulder blades, often. It's from the other muscles. So.
Okay, can you explain this again? Because it just seems like it should hurt where the problem is.
Well,
I don't
it's
understand.
80% likely that it's caused, the pain that people could be feeling is from another area than where it's hurting. Mm-hmm. So it's 80% likely. So it's 20% likely that's why you say, people often say, I keep treating there, I keep treating there, and keep treating there, but it never goes away. Because a lot of times the pain is from, 80% of the time is from someplace else. So we're looking at both the someplace else's and the areas right there that cause the pain. So there's four, they're right there, and they cause the pain right there.
And we're just supposed to accept this? I mean, how, this is just, it's like you're making up anything you want. You say, there's a trigger point here, and it hurts in your nose. I mean, how do we really know this?
Okay, so one of the things that Travell and Simons and other doctors like Dr. Fisher did was they used saline and they injected into these areas, and then when they did that, these really bright, painful areas stuck out like this. And in some cases, this whole area that you see was in pain, mm-hmm. and sometimes it was just these more dense areas. So it's like a distribution graph. If you had 100 people that they injected and with the saline without the painkiller, it would cause this kind of a pain pattern. Mm. So they did this research a long time ago in the 50s, 60s, 80s, and Travell and Simons came out with their books in the 80s and 90s.
So you're saying each one of those little dots?
Each muscle in the body has referred pain patterns, just like the heart. The heart's a muscle.
Oh, yeah.
You know how it has its referred pain. So the muscles are like that too. All the other muscles are like the heart, and they also have referred pain as well. And when it's referred pain, you often think it's an organ or a heart, because it feels so deep and achy. It doesn't seem like a muscle, so it feels much more, it alerts you. It keeps your midbrain awake, and you're very alerted, and you're it keeps you a little bit upset because you can feel that deep, achy pain all the time. So the most likely one in the whole body that causes the pain between the shoulder blades is the side of the neck muscle.
No kidding.
So it's the most likely. Now the second most likely is the latissimus dorsi. Let's take a look at that. So that's a muscle that starts way over here on the hip and comes all the way to the arm, and it causes pain right there, kind of lower, a little bit lower than the scalene and the anterior serratus. Then the fourth one would be the iliocostalis. So this is an up and down back muscle. Let's take a look at that referred pain of that one. And you can see it right here. This is the iliocostalis and its pain pattern. And it comes across the shoulder here. So we're going to take a look at the iliocostalis in there and how it causes that pain in here. And this is the muscle right here. And it attaches here onto the lower cervical. Okay, so let's take a look at the next one. So that's a lot right there.
Well,
but there's quite a few muscles right in the shoulder blade area. The multifidi, the rhomboids, the posterior superior serratus, and the trapezius. They're all like on top of each other, right?
Yeah, right. Is that what all those little squares?
Yeah, we put those. They're all on top of each other.
They're all on top of each other.
Okay.
So
we're going to treat all these all at the same time.
Like a big trigger point muscle sandwich?
Yeah, like a trigger point muscle sandwich. Well, each one has some really interesting pain patterns, but they all cause pain between the shoulder blades.
Oh, and what I noticed about those is that they're kind of so those muscles are in the region of
that's right
between the shoulder
so in this
blades.
case there's 1, 2, 3, 4, 5 muscles causing the pain that are in that area, and there's 1, 2, 3, 4, 5 that are, so it's 50-50 in this case. Not 30, it's 20-80, but it's not uncommon to be 80, but in this case it's more 50-50.
Well, thanks for explaining that again. I think it's really neat to know that these are distribution graphs, and that X is where the trigger point is, and each one of these dots represents where multiple patients experienced pain, and all, so it is really a distribution graph, and if people get too caught up in the why, sometimes you just say, well, we didn't make the body, so maybe we don't know why, but we do know how.
Yes.
This graph tells you how pain arrives in those areas.
Now let's take a look at the rhomboid muscle. So this attaches onto the spine and onto the shoulder blade. And you can see that it causes pain between the shoulder blades there, as you would expect.
Yeah.
And the trapezius right here causes pain here, right here, between the shoulder blades. So it's this lower part does it, the middle part does it, this part right over the shoulder blade does it. So you've got these all causing pain between the shoulder blades.
Oh, that's neat. So you're saying the trigger point that's at the far top, almost where the acromion is?
It causes pain pretty much right there. But the one right over this part of the shoulder blade,
little black one.
there, right there, it causes it to be in this little arc like that. So it causes it between the shoulder blades. Yeah.
Okay.
So that, and this lower one right here, it causes significant pain throughout this region right here, right there, and up all the way up. So it definitely causes pain throughout. So this lower section causes it to hurt upper.
Wow.
And we have one more muscle in that area, I think, if not one more. Here's one more. And this one attaches onto the ribs. And to get at it, you have to move the shoulder blade that way. And here it is, and it causes pain here, but it's hiding. It's a deep one, and it hides underneath, and you have to find it.
Oh, so because that almost looks like it's the infraspinatus on top of the shoulder, but it's actually beneath the shoulder blade?
It's under.
Is that why it's white?
That's right, that's why it's white.
Okay,
That's
so
right.
on this
So
chart it's
different.
white?
That's to show it's a little different. So it goes through, it's going through the shoulder blade there, the X. But then look it causes significant elbow pain and significant wrist pain. And guess who came in with this? The Chicago Bears. They came in with this pain in their elbow. And this was hard for people to find because they'd have to look there. And this was not one area that people looked for.
So you're going to have to move the shoulder blade out of the way to get to it?
You do.
Oh,
we're going to do that. We're going to do that, yeah. So those are all on top of each other, and we're going to treat those. And then we're also going to treat the infraspinatus.
Okay.
And that's that one where we do this
right.
test like this. And that's the infraspinatus right here. This one causes pain. It doesn't show in this picture, so we'll have to pull the other picture out. But it causes pain right here. But this one it's missing it, but it causes pain right in that region.
Okay.
So that's the infraspinatus and the serratus anterior. We got them all. We got them all. We did it
got
all. But wouldn't you say it's incredible to think this muscle here on the side of your neck causes pain between your shoulder blades? This muscle here in the side of your back coming up here and attaches onto your arm causes pain right here. This one on the side of your chest causes pain right here.
Yeah.
So many times I just know that those muscles are probably going to be bothering people, especially if they have pain between the shoulder blades and down the arm and into the hand.
Oh yeah, if they got a real bad elbow too, then I guess we're going to be looking at that posterior. What was that called again?
That's the posterior superior serratus. It attaches onto the spinous processes there and then onto the ribs. And its job is it just elevates the ribs when you're running really hard. Yeah, so
that's maybe why the Bears would have it activated.
Well, it could be so many reasons.
Yeah, I guess so.
Yeah. So, but they also this one they also had this muscle right here was bothering the anterior serratus and the pecs. So I was figuring it was definitely a combination. Yeah. It worked just like a snap.
Well, I could say from my experience with chiropractic college that they only covered the trigger points that had a logical, similar area. We never referred pain you know, if it was too far away, it seems like they didn't include it in our training.
Yeah, they did. They didn't like those distant referred paint patterns.
It's really strange.
Oh, they just the really obvious things that would be
the
right
obvious
there.
ones. Yeah.
So here we can. This is something that you can download potentially, right?
Oh yes,
Justin?
it's available. Yeah.
So this shows if you're a therapist or a patient and you'd like to look at all the muscles that cause the pain and picture. I have the muscles right here, the levator scapula. I think I might have missed talking about it while we were.
Oh yeah, we didn't mention that.
Maybe I missed that one. Yeah. So that's what this one right here, levator scapula. It causes pain right in here in the shoulder blade right there.
Yeah.
So so here's all the muscles, and you could print this, and then here's a bunch of the stretches that we could do. But there's lots more we could do. But this is at least a few, and that gives you a few to get started with.
So you print this. This is ideal for the patient to take with them, and then when you go through, you take your fancy highlighter, also what I call the compliance tool, and then you highlight the muscle. Maybe Sharon can show us how she does that again with
I got the highlighter. Right?
Highlighter and a pen.
So I like to do this. So I would. So
This
if you're
is how you
saying the
personalize
scalene, so I highlight the scalenes, and then I make note that they attach on these two ribs, and then I might also show a tool that I might use to treat it. So I might use a jackknobber like this, and then I go point at it. That you'd use the jackknobber, or maybe I might use the back knobber, and then I draw that in. Then I pointed it that way. So that's a good way. Maybe I'd like to use a ball on the wall here, so I put a ball. So I'd highlight this one, and then I put, a ball on the wall, and I'd say, treat this area with the ball on the wall.
Yeah, beautiful. When you do that, this now has become meaningful and very useful.
Now this one here, the only way to get this one to work would be to move. You have to move the scapula this way, and then you put the ball where the scapula used to be. So you put ball on wall where the scapula used to be. So then you could put a ball there on the wall. Okay.
That's great, and that, along with showing them how to do it together in the treatment room, really it solidifies and makes it so easy.
And then here's this anterior serratus, the infra, the trapezius, and the paraspinal.
And these were costly to put together, so we hope that you guys will use them and enjoy them. We know that the head and face ones, some of them were still hand-drawn, but from here on out, most of them are done by a very excellent professional artist who drew them as well as I've ever seen them in any of the books.
Yeah, very nicely done.
Yeah.
Okay, so we're gonna so hopefully all of you have been warm. If you have your heating pads, take a look at. So it's nice to start with your treatment with heat. Then we're gonna do compression. Often we might test the range of motion and compression after we determine which muscles and taut bands need to be treated. And then we do range of motion. So that's our
three-part assessment, three-part treatment.
Yeah, so that's what we usually do. We're going to take a look at some of the tests. So we've been warming you up, so you'll probably be better at your tests.
Okay, we go to, let's see, since I don't know them by heart, I go to 12.
This is the muscles. These are all the tests that we're going to do today.
Okay, great.
So this is, we're going to look at the nerve roots C2, the C8, T1 to T9. We look at tests 1, 2, 7, 12, 14, 15, 19, 19A, 28, 36, and 37. So there's a lot of tests. But
there'll be lots of repeats. You guys are experts at most of them by now. Well, half of them maybe.
So we'll take a look at, so everybody could do these tests along with us.
Okay.
And so you could, so let's start with the first one here. So a cervical rotation. So let's do it with you seated. Sit down here with your back towards me. Okay, so we're going to take a look. We're going to have the person, so we're we'd like to get their nose to come to their acromion. So we're looking to do that. So let's see if you can get your nose to come all the way over here. Pretty good. Oh, that's coming right along. So we're only about an inch away from that. That's pretty good.
Okay.
Let's go on the other side. Whoa, you go all the way. She passes on that side.
Okay.
with flying colors. That's rotation. So the left pass, right,
Mm-hmm.
minus, like it was about a little bit less than 2 inches. Okay, and so that was good. So then we're going to do lateral flexion. So let's see if we can get how close we can get your ear to your shoulder. We can measure today with our fingers. So we'll see how close we get. So we're about 3 fingers. That's good. Okay, so we're going right from the ear. So we're going this side. Oh, this side. 2 fingers. 2 fingers. So that's good. So that's
Well, ideally, it's
that's
no
pass.
fingers, right?
And well,
Oh,
it's good, but you know, I would say that it's unusual for someone to be as good as that ideal.
Mm-hmm.
So I would say that that's pretty good a pass, but I'm going to put here minus 2 fingers.
And I keep forgetting, I will upload this onto the website so you guys can download this sheet to mark the results. But basically, you know, any kind of documentation is good. As long as it works for you, then that's the main reason.
Sure.
Yeah.
Okay, let's also do cervical flexion. Let's see how you do with that. Let's go ahead and bring your chin to your chest. Good, she's squeezing my finger. Good, that's a pass.
All right.
That's a pass. That's good. That's pass, good. And extension, we could go ahead and let's look at that again. Let's see if you can get your nose to the ceiling. Yeah, she does that really good. So you can see she's getting her nostrils towards the ceiling.
Yep.
She does that very well.
Okay, good.
So that's done really good. So she passes that. Okay, so the scaling figure flexion test. So let's go ahead and you can watch her do it over here.
Okay.
So let's go ahead and put your fingers on the wall. And we're going to put all your knuckles on the wall, and you're going to bend them. Keep your, oh yeah, nice, very good. So super great. So you're passing. That's good. Okay, let's try the other one.
And again, if there was, we'll look at.
No, we have a non-passing over here. So here's a non-passing. So put the passing and non-passing together here. Okay, so here you keep your knuckles onto the wall, and when you do that, there's just a little space, but it's not too bad. That's too bad. Let's check the other side. Okay, so yeah, they keep your knuckles right on the wall, so then you know, oh, I gotta treat my neck today. See, I gotta treat my neck today.
And that's due to nerve compression.
Yeah,
by
so that's
scalenes?
when those scalenes, the first and second scalene, or the third pull up on the first and second rib, particularly the first and second pulling up on the first rib.
Yeah, it compresses the nerve, and then that causes
the brachial plexus.
difficulty
Yeah,
with the.
well, it causes heightened tone in the entire arm.
Wow,
all
heightened
the
tone,
shoulder,
entire
heightened
arm.
tone, all the shoulder blade, everything. But you could. This test is expressing that it goes all the way down to the fingers.
Oh wow.
So it's catching all the way down all the fingers. So it's getting both sides, the ulnar side, the radial side. You know, it's catching everything.
Yeah. And when you have that heightened tone, you just can't put those pads.
Nope, you can't. No.
Yeah.
So then we know that we fixed it when the pads easily touch.
Oh yeah.
Yeah. So
So
that's
by the end of the
so
treatment.
it's very likely that you can pass. Yeah. And then if you keep doing it over and over again, then the body learns that the more longer position is the normal regular position, and not to go back to the short position again. So you often need a lot of repetition, because it's learned to be short, now it has to learn to be long and full function. Long and fully shortening, fully lengthening and fully shortening.
Amazing.
So that's what we're looking for. Okay, our next test, so you passed that. You did that. So that was good.
High five.
So let's do the mouth wrap test. So that's this one here.
This is awesome.
So you're trying to get to the middle of the mouth. So here it's about a half an inch. So that's minus a half inch, but that's hardly significant. But it's be interesting to see if we improve. So here, oh no, it's about it's a half inch.
No, not quite.
Okay, what muscle is this one?
This is the most likely one. So this is on these range of motions. It tells you the most likely one to cause the dysfunction is be the infraspinatus.
Wow.
So that's the muscle. So then the middle deltoid, the supra, posterior deltoid, teres, latissimus dorsi also tests for that. The levator scapula, the splenius cervicis, teres minor, and corcobrachialis. Yeah. So it's a test for all of those. And then the one where they feel it and there is painful, you could circle that one. Yeah. So it gives you a little cheat sheet on what muscles you might want to look at.
Okay.
Okay, so that's a pass for you.
And how about the other side?
Go ahead.
This one's worse for me.
with what was a minus hand.
Oh.
So
Oh, poor dear.
Oh, I don't even get close to my mouth.
okay, good. Well, we have goals for you.
There are goals for me.
Okay, so we're going to take a look at the upper trapezius a little bit. So we're going to do this test here where we have the thumb down. We're going to do a little bit of resistance, so go ahead and resist. How's that feel? Oh, she's substituting a little bit, so that we know that there's probably the deltoid, which we're not treating today, very likely, but it's making this much. When she's trying to use the deltoid, she's using her trapezius. So that's a substitution. So that's not a pass, okay? Okay, and the thumb up, and thumb go up. Mm-hmm. Okay, good. So now that you passed that part. Okay, so but you need some work on that. So let's go ahead.
So she failed because she had pain, or
she was probably because she wasn't using her deltoid, and then the trapezius had to do the deltoid's job. Yeah.
Okay.
Yeah. Go ahead. Good. And let's do the other way. Okay. Yeah. So we're gonna see if we can improve that. So probably for that we'll have to treat your deltoids. But in addition, it's a good one for trapezius. So deltoid and trapezius. So we're failing that one. And we did that standing. Yeah. Okay. Good. So let's take a look at that again. We would like to do that overhead reach, and so that would be where we're going to go like this and clamp over your head, and then we're going to see if your arms come close to your ears, and they do. That's a pass. And then we see that it's a little bit to this side. Let's see if we can get you straight. So it looks like you're a little tighter on this latissimus dorsi here. Probably it feels like yeah right there. Yeah. so it's a fail on the left, pass on the right, and that's lats. So I'm going to circle the latissimus dorsi there.
So what is it supposed to be?
It's supposed to. Both the hands are supposed to come up to even, and then you're supposed to be able to get your arms next to your ears, and you shouldn't be like this way.
Okay.
Like that, So to one side.
Okay.
Yeah. But I mean, it could probably be corrected from just our treatment today, so it should work pretty good. So let's take a look. Oh, I missed that one. Okay, thank you. Okay, so we're going to take a look at internal and external rotation. So here, we're going to put the arm at a right angle, and then we're going to come back like that. Oh, you pass. That's pass. Yeah, it's pass. Let's go in. Oh, it doesn't like in.
Ooh, it's supposed to go all the way down, isn't
down. It doesn't like that.
Oh, what muscle is this?
That's subscapularis and latissimus dorsi.
Latissimus dorsi.
Yeah,
wow.
and that's also, remember this way, latissimus dorsi didn't like that test. Okay?
Ah, okay.
So it also doesn't like this strength test here. So it doesn't like
wow.
that shortening. So we have to correct that, so that especially the internal rotation.
So
that's B.
External rotation is supposed to go a little beyond 90, is it? Or 90?
Yeah, 90, yeah.
90? And that's supposed to go down 90 too, huh?
Yeah. And so we could measure that with our goniometer. Go ahead and let's do it again. So we could measure it. So here we should have 90 plus.
Wow.
And then internal it should come down. So really it's almost.
It's almost 45. Wow.
It's quite came up to there. Yeah. So it shows we almost have right there. Yeah. About 45. Yeah. 45 degrees, minus 45 degrees.
Wow.
So that's minus 45 degrees. Okay, let's look at the others, internal and external. So this is really important to keep these. This is ideal. And this. This is really good here.
Oh, yeah.
Okay, and then here. Okay, so substitution a little bit. So it's about to here. Yeah. So it's pretty good. Pretty good on this side, but it could be just a little bit better. Okay. So this would be about 10 degrees. And so we'd want to improve that a little.
So in both those tests, it was worse on the left?
And the internal rotation, the external, she passed.
Okay, great.
And they was both worse on the left, yes. Yeah, left was left.
Somebody's got a left lap. left. Okay, so we have 28 is a flat back test. So we're going to have her sit on my chair here. Go ahead and sit. And then you're going to have you lean forward, put your knee between your knees, put your hand between your knees, and let's try to bend at every vertebrae.
but don't not let your hands go.
Oh.
Yeah. Okay. So so we're seeing where does it feel tight? You're between, like, where does it look flat between like two or three or four vertebrae.
Mm-hmm.
So here it feels kind of flat.
Oh
Right
yeah,
here.
mid-thoracic.
Oh yeah, all flat through there. Yeah. So I would say it kind of feels kind of flat in here and through here.
When you have anterior thoracic segments like that, you usually
yeah.
have a lot of tenderness
Yeah.
in the spinous ligament too. So.
Yeah. So thank you. So it looks to me like we did that seated, and we found quite a few flattened areas in there. So we'll see if we can get them to move. Let's see about you. Let's try the standing toe touch. And do you usually touch?
No.
Okay.
Or sort of. The floor.
That's good. You touch. Yeah. Okay. That's good. She touches. Okay.
Otherwise, you could measure from the tip of the finger to the floor, and that would be a way of documenting.
Let's check. So should we check you? Oh, she's good too. Okay. So let's check. Let's just go.
Pretend to be bad.
Pretend to be bad. Yeah. Okay. So then you can measure from the tip of the finger to the floor. That's not very bad though. You have to get worse.
Oh, okay.
Okay, that was real bad.
Okay. So that's 7 inches minus 7 inches.
Okay, great.
Oh yeah.
I'm gonna be real bad. You
Oh,
really
she's
can
bad.
get
Oh,
down
she
yet.
can
I'm
do it.
gonna
Oh.
be bad. I'm gonna be bad.
All right. Well, you're good. You're good. You're good.
Okay.
Okay. So all right. So we found a lot of things to look at here, and let's go ahead and let's treat these. Let's also look as you're standing, and let's look to see if we have any heightened tone in your spinal segments. So which segments did we want to look at today? We were looking at a C2 through C8 and T1 through T9. So we're going to go all the way from here, all the way down, all the way down. So we're going to look here. So you can see, let's go this a little bit so he can see us good. And let's not have your head, yeah, that's good. So here, we can see that we've got the C's are pretty good, but as soon as we get to the T's, we're tight. Very tight, it doesn't lift up, see, I can't lift it up. So it's hard to lift up. So especially these T's right here. Yeah.
Mm-hmm.
So here, we're getting a little better. Oh, but we're a little tight down here. Right down there. So
Were you laughing because it was tender, Stephanie, when she got to that point?
It's tender.
Oh yeah. So T 12, and then your L's are too tight down there.
So
So
again,
but you know, the next class
what?
we're going to be doing the lower thoracic, and then we're going to be doing the chest,
Wow.
and then we'll be doing this part. So it's all
Yeah.
coming up. It's all. We'll be treating all these areas.
So again, this is the little muscles in the skin right here will have heightened tone, and the likelihood is that because of nerve compression, there'll be heightened tone throughout the entire distribution of that nerve.
So we'll keep that in mind when we're treating. When we're treating ourselves, if we can't lift it up here, then we want to treat it right along the spine.
Yeah, so
That'll be part of what we'll be doing.
yeah,
So,
that's what you're feeling. That even as you're pulling up, you're also feeling for the tone, and that's why Stephanie could feel it when she got to this one spot, because the muscle tone was increased and also it was tender.
okay, so for Stephanie,
It's very rewarding for your patient to see that you go, oh, that's that spot, and that they feel it too. So that's how they build confidence that they know you know what you're doing.
okay, so hopefully people have some nice tools at home to use, or some balls that we can use. So we're going to start with treating ourselves, and we're going to do a quick treatment on ourselves, and then we're going to. Okay, so here I put some warm water here, and it's nice. I'm going to use a back knobber tool. I'm going to put the warm water here to lay on, and then we're going to also, while I'm doing this, also Stephanie is going to treat herself as well. And then we can see what Stephanie's doing. So here I'm going to come like this. So I'm going to start with us laying down. We're going to treat some of those muscles that we just talked about.
So these are the 5 of the 10 that are all on top of each other.
That's it.
Okay.
Okay, so it's good to get yourself right on the hot water bottle, and then you could take your tool and you could come underneath your body to the other side. You can see I'm over here.
Wow.
And you could get really close to the spine. And if you had as we tested her, so we could go right on next to the spine, right at T4 for you. So T4. So let's go right to T4, and you can see that you could use the tool and not have to do very much pressure. Look at, I'm just using 2 fingers.
Wow.
And breathing and relaxing. I'm right next to the spine, but right
So she's pushing this way,
this
and
way.
then it's lifting up.
Yeah, it's lifting up and pressing into the back. And Stephanie, could you go to T4 and turn around so he can see where you are? So that looks pretty good. So you finding the spine, you're getting right to this, just to the side of it, and this is where the little multifidi muscles are in the rotatories.
And your hands are just like that. Is that comfortable?
Yeah.
Okay, good.
Now let's move up a little bit. So let's go a little bit. Let's about a little bit where T3 would
The only
be.
thing Stephanie has to say, why don't you
Now
come
what you
over
wanna-
your arms so that you're not hiking your shoulder?
Yeah. Oh, good.
Yeah.
Thank you.
Yeah, there you
Thank
go. Much better.
Good. Thank you, Justin.
Mm-hmm.
So now what we're doing is we're looking for a painful, tight spot that feels burny or painful and refers or just even causes pain right where you're pressing. So I'm holding it, breathing and relaxing, and as if it's a painful spot, let's go ahead and let's move it up a little bit. So let's find the spine. Let's come just to the side of the spine, and we're going to go ahead and press in and pull the tool to the opposite side, breathing and relaxing. Breathing and relaxing. I'm looking for painful spots, pressing on hard, painful spots. Now what's in those hard, painful spots is painful sensitizing chemicals. Those chemicals are holding the muscles in a stasis, and they don't have a good blood supply, and they're, you know, the nerve, when it comes to the muscle isn't ready to do its job. Now we're pushing those painful chemicals out, and we're letting the blood supply passively come in, and we're getting homeostasis back, and you're getting nutrients into the tissue, and then it's able to do its job. So we're coming up a little higher to T1. Let's go just to the side of the vertebrae, to the side of the spinous process, and we're going to press in and pull it to the other side.
And would you generally always do the correction of the
Well, you could do it, you know, one way of doing it is do it first. Okay.
Well, yeah. Mm-hmm.
Now that's good. That's kind of like looking at it from many people's, like Dr. Fisher, we always say, look at that first.
central to peripheral?
That's right. But then Dr. Simons didn't, or Travell didn't always look at it that way. But they wouldn't be against doing it that way. But they didn't focus on it as much.
Mm-hmm.
But you could always say that if you didn't find good success with treating those muscles, you could go to the nerve roots and see if they're really tight and dysfunctional and treat them afterward.
Yeah.
So you could look at it one way or the other. Now I'm going to go on the other side. So we're going to go to the right side now. And we're going to take the tool and I'm sticking it across to the opposite side. And I'm just I feel the spine at about T4. And I'm going to look for painful hard tissue. And I'm going to press on it and squeeze those painful chemicals out of the hard tissue. And when you have the heat on the person, like I have on myself, it sends a message to the brain faster than the pain message and encourages you to relax. So it's a good way. And if it's not painful, you're just going to go ahead and move it on to another spot. And you're looking for those taut, hard, painful spots. So here, I found a spot that's sort of painful. And now I'm going to hold that spot, breathe, and relax.
So the knob on the back knobber, or the big bend, is really on the other side of the spine?
That's correct. In this case, so are you putting it on
And
the
this
same side
one,
or the
it
other
would
side?
be on this side. Look for a second. It'd be on this side.
That's correct, yeah.
Yeah.
But it's not critical to do it, but it's a good way of doing it. So you can do it on either side, but that's the way I'm doing it right now.
Mm-hmm.
But for sure, you can do it on the same side as well. But look at this big tool. It's got such a big reach, and so it has such a great power. So just even with hardly putting any pressure on it, and your body weight on it, you're able to go and use very little pressure, but it really does a terrific job on those little muscles along the spine.
Wow.
And let's come up a little bit to T1.
Well, this is just so neat, though. I mean, you've got all the heat. You're lying on top of a Foamintech bag.
That's right.
So you've got all this relaxing heat. If anyone hasn't laid on a Foamintech bag yet, they are remarkable compared to other forms of heat. They're really, really nice. and then you're doing the compression at the same time. So that's killer. It's
Yeah,
great.
it's easy to do. You can just get the tool underneath you there. Okay, so then we could look and see, did we do any good? Did we do good? So you'd have to have a partner just to check to see if you did a good job. So I could check you. So I'm gonna roll to one side and get up and check you. So let's check you. Let's see if you see if Stephanie see if Stephanie did a good
Well,
job.
she's a musician. You know.
Okay, yeah, that's a little better. So that came up a little better. But here it's still tight. So, so it's right here at T1, it's still tight, but T2 is better, T3, and C7 is nice. So, right, there's one spot right there that's still a little bit tight there. Yeah, but you did very good, so some of them improved. Okay, so that was one of our first muscles, but then we're also going to treat all these other muscles here. So we're going to treat the rhomboids, which go from here to here. We're going to be treating the trapezius through this region all the way down to here. So we're going to go ahead and do that while we're laying down for a minute. We'll treat all these areas. Here, 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 all through here.
And for those of you that didn't catch it, if you just watch Sharon's patient skills, her patient communication skills, she had the patient work a little bit on themselves, showed the patient how to see if they've improved, and she gave them encouragement, saying, "See, you were able to make a difference." And earlier, when she was not doing well on one test at all, she said, "Well, you've got some goals."
Okay, good.
It's always positive, keeping it very positive.
That's good. Okay, so let's take a look at. I'm going to go ahead and get on the table here. Okay, so we're going to go down to T12.
Okay.
And let's feel to T12, and that's our trapezius. And we're going to go in there, and because it's this, look at how huge this tool is. It really reaches a big distance.
Yes.
So, but if you had the smaller tool, go ahead and give me the smaller tool. You would be more encouraged to work on the same side because it's a little smaller. See, but because this tool is bigger, you can reach all over the place with it. So I like it because you can reach every place, all over the butt, everywhere, all over the sacrum. Right now I'm going to go to the bottom of the trapezius. So I'm going to press in there at about T12 on the other side and breathe and relax. And again, you don't have to use very much pressure when you're doing this. So you could just use just a very little bit of pressure. Breathing and relaxing. And when you're breathing and relaxing, notice if you're tightening up the scalenes while you're breathing. You don't want to do that because they're accessory breathing muscles. Let's go up a little lateral. Let's go up towards the shoulder blade, and let's look for some taut bands. Now this one is the one. Oh, she knows that one.
She found it.
That's the one that causes that pain all over between the shoulder blades, right there. Yeah, it causes that lower one. That's trapezius number 3. Causes it to go all the way up to the base of the skull.
Oh, yeah.
And let's go up, and let's go right on the edge of our shoulder blade. Let's go right on the edge of the shoulder blade. Right on the edge of the shoulder blade, and let's keep coming up higher. And let's go right. Keep coming up higher.
So this is obviously something that's very nice to do in bed.
You could do it in bed. You really could. Now, see how this big tool. So this, the pressure positive people, they like to call this the big bend, and you kind of have to order it special because you don't see it everywhere. So but it's a nice. I prefer this over the plastic because it's so fun to use. It's good when it's fun. So we're out here, out on the shoulder, over the shoulder, a little bit over the shoulder blade. And let's go ahead, let's look at the other side, same thing. So I'm going to take this tool, this large tool. This is called the big bend. We're going to put it underneath us. I'm going to arch my back up a little bit. Come underneath, press my back down on top of it. I'm onto the other side at about T12. I'm going to press in, and I'm going to press my back down onto the tool and press the tool away from me. And it's going to just breathe and relax. Oh, just breathing and relaxing. And noticing how you're not tightening up your neck at all. And then you're going to go to the next, you can arch your back up a little bit. You're going to go to the next spot, so the edge of the trapezius. Now we're pressing our back down onto the tool. breathing and relaxing. If it's not painful, go ahead and move on to the next spot. So let's keep coming out. Let's go to like the bottom of the shoulder blade, and let's go ahead and press on that and breathe.
It's about T6, right? The bottom of the shoulder blade?
Yeah, that'll be quite a little, several inches higher, yeah. And let's come on up. Let's go right on the edge of the shoulder blade, and the inside edge, or the medial edge of the shoulder blade, and that's the spot. Breathing and relaxing. And let's come up a little higher. And get right high as you can get with your tool. Breathing. Oh, and relaxing. Okay, so we got quite a few muscles while we were doing that. We got a little bit of the iliocostalis, a little bit of the trapezius, a little bit of the rhomboids. So we got a few muscles in there. They're all on top of each other. And then let's move them around, these muscles we just treated.
Oh yeah, that's right.
Let's move them a little bit.
So this is the third part of the treatment. There was heat, compression,
We can do it together.
then range of motion.
Yeah, so we're gonna pull our trapezius back and down. And let's bring it forward. And let's bring it thumbs out and bring it back. And let's bring it forward. Let's do one at a time. Let's go in and out. And in and out. Let's do the other side. And in and out. And in and out. Good. Both together. In and out. And in and out. Let's really rotate. Let's keep our hips forward. So we'll keep our hips forward. Let's really rotate those multifities. Let's really rotate our multifities. Let's really rotate. So we're rotating these little muscles right here. So think about how to rotate those. Rotate these. So let's think about how to rotate these. Okay, great. We did it.
Great.
Okay, so let's do. We want to do the top part of the trapezius too. So let's do a little bit of that. So let's go ahead and take our tools and let's take a look at the top part of the trapezius. So we already warmed it up nice. So let's go ahead and do some of the muscles on the top part of the trapezius, and let's feel the acromion, or right where the collarbone is, or right where the shoulder is, right there. We're gonna press right on that, and let's see how much range of motion we have to the opposite side. And let's come a little closer to our neck, and let's go ahead to the opposite side, and come up straight. Let's come a little higher to the crook of our neck. Let's go to the side, and let's come up a little higher.
Oh, you're very welcome. Someone thanked us for those charts. They printed them this week, and they're finding them of value.
Oh, great.
Yep.
The referred pain,
Yeah, the pain key chart, the master,
the Rosetta Stone.
the Rosetta Stone.
Okay, so get right on the trapezius as it's coming up here, and as it's attaching onto the occiput. Okay, let's take a look at the other side. So let's start on the edge. Let's start right where the trapezius attaches onto the collarbone and onto the acromion, or right onto the shoulder blade there. And so we're going to press on it, and you can just kind of put the weight of your hands onto it, and then you can just feel the bands that you're pressing on. And you can see, oh, I'm pulling right on those bands that go to that side.
Wow.
Are they tight? Can I get them to loosen up a little bit by doing this? Now you might do this right in the morning when you get up in the morning, and do this right in the shower. Take this to the shower with you, and do it with heat in the shower, right on this section right here, and it doesn't feel as painful when you're using heat.
Well, that sounds lovely.
So we just did the top part. Oh, and we want to come up a little higher like we did before. So let's come up and get this section of it too. So we get up right here, and we'll lean our head forward. We'll come to this part of the trapezius. Now, We're going to get right onto the levator scapula as well. So let's feel where the levator is. So here's the top part of the shoulder blade right there, the medial angle, superior medial angle. So we're going to press right on it, and we're going to we could elevate the shoulder and depress the shoulder, and elevate it and depress it. Let's come up a little higher. Let's look for some painful spots in there. So let's go ahead and see if it can do its job. And let's come up a little higher. It's attaching onto the transverse processes here. And a little higher. And let's take a look on the other side. Let's take a look at where it attaches. So here's the levator scapula, so it elevates the scapula. So let's go ahead and press right there. So we're gonna have so tip our chin down into the opposite side, and let's elevate the shoulder and depress it. Let's come up a little higher. Let's elevate it and depress it. Now this is one of the ones that cause pain between the shoulder blades. See, it's a neck muscle. It comes all the way up here. It's a shoulder neck muscle.
This is the third most likely muscle, the levator scap.
That's it, the third most likely one to cause pain there. So let's do a little range of motion exercises for those areas we just did.
Okay.
So we're going to bring our shoulders up and our shoulders down, and our ear to our shoulder, and our ear to our shoulder, and our shoulders up and down, and ear to our shoulder, and ear to our shoulder. What I do, I realized I had to do more range of motion of these muscles than I used to do. So I used to have headaches, and I realized, oh, I have to keep moving these muscles more. So a lot of times when I'm walking around and I'm in Chicago, I might look up at the skyscrapers and then look at something else, and then I might look at something else over there, and I look at something underneath here and over there. You know, so I look at the corners of the rooms. So I go, oh, what's going on over there? And I look over, oh, what's going on over here? So I look like I'm looking for a friend. So I just add these ranges of motion in all day long.
That friend wouldn't be a pigeon, would it?
I hope not.
So I look around for things. And so that's how I use it. So every place I go, I really use my neck, but I try not to be like I'm exercising. I try to be like I'm just looking around.
You're a tourist.
Yes,
That's
you're a
it.
tourist.
I'm looking around. So another muscle that we want to learn to treat is the anterior serratus.
Oh, so we're done with the muscles that are all in the same sandwich location.
Well, did we get them all?
I thought we did, yeah.
We didn't do that special one, the serratus posterior superior, because we're going to do that.
Oh, the one that's underneath the scapula.
Yeah, we're going to do that one. We're going to do that one in a minute. In a minute.
In a minute.
Yeah, in a minute. Okay, so we're going to take a look at the anterior serratus. So this one, let's be nice to take a look at.
Man, is this crazy important. Everybody must learn this one. This is a home run muscle.
We got to learn
wouldn't
this
you say?
one. Yes, it is.
It's a home run muscle. Why? It has some kind of historical significance.
The anterior serratus.
Yeah.
Well, what I think is historical about it is that it causes that horrible pain between the shoulder blades. It never goes away.
Yes.
So
and
that's
then
good.
somebody was digging around in there, wasn't it Dr. Travell or somebody, and was feeling around in there, felt these little BB-like, knots, and then it alleviated all this pain behind there?
Well,
I may be confusing
that
stories.
was it's certainly it happened with one of the muscles, so it could have happened with this one for sure.
Okay.
So here's the muscle right here, and you see it attaches onto the first rib, the second, the third, the fourth, fifth, sixth, seventh, eighth, and 9, and then it attaches onto the inside border of the scapula. So we're going to try to get up in through these muscles here, and it's one of its main jobs is holding the scapula down. It holds it from winging out. Now, if this muscle right here is tight, right here, the posterior scalene, it could cause the shoulder blade to wing out like this. And that's because that'd be nerve compression of the long thoracic nerve.
Oh.
So we could correct that for sure. I've seen that many times, so it's definitely something that can be corrected by treating the posterior and middle scalene. but we're going to treat it now while we're standing. So we're going to get right up in here. So let's feel the edge of our shoulder blade right here. We're going to get really high right in there. And we're going to press and look for painful spots right in there.
Uh-huh.
And we're going to look for painful spots.
So you're pushing back against the inside of the scapula, the underside?
Yeah. And then we're going to stretch it, okay? And we're going to come right here. So we're looking for hard painful spots right in here. Oh, I found a little painful spot
I've
there.
got a couple ouches.
I found a little did you find any?
Oh, yeah.
She found one.
I found one.
Yeah, she found one, so it's right there.
So this wasn't the one that seemed like almost a heart attack-like muscle? I'm thinking of a different one then.
Well, look at it causes pain down the arm. So like as much as it's
That's
true.
what I thought. I
So
thought there was a
could
story.
Be, but it could be, you know, it definitely could be. So let's take a look at how it causes. So here's the anterior serratus.
Yeah.
It causes pain there.
Yeah.
But it causes pain right between the shoulder blades, and then it does cause pain down the arm.
Uh-huh.
So when you have these referred pains that run down the arm, and it sometimes does make you think you're having a heart attack. Yeah.
Yeah.
But part of the thing is this muscle is right on the chest.
Yeah.
So it could be, you know, it makes you think you're having chest pain. You know, then
Mm-hmm.
yeah. So this is one of them. This is only one, and several of them. I've had some people that went to the emergency room 20 or 30 times, 22, 23 times, and they hated them. They said, the emergency rooms hate me. I keep coming in because they had these muscle dysfunctions that were
Yeah.
causing them to have panic attacks. You know, if you have this compression of the scalenes or the compression of the long thoracic nerve or some of these others, you could have, or, you know, even the sternocleidomastoid and these others, if they're causing referred pain, people get really scared and think that they're dying.
Yeah, they get
Yeah,
hysterical, yeah.
Yeah. So here, did you find any painful spots? She did find some painful spots. Now, she actually had shingles, and so she probably has some especially painful spots in the chest, right? Yeah. Yeah, which area did you?
All over the left shoulder
Uh-huh.
and then in the front of the chest.
So here, we'll start up high again. So let's come way up high, way into the axilla, way into the underarm, right there, way into the axilla. And then we're going to press in using the tool. And we're going to press in breathing and relaxing right in there. And let's come down a little bit inferior to there. So that'd be, then let's go a little bit more inferior and come right here.
Mm-hmm.
And let's come down and come down a
And when
little
you hit
bit
the right
inferior.
spot,
Yeah,
a little sound will emit from your anterior serratus.
That sounded-
Yep, that's the sound. You have now hit
Uh-huh.
the right spot.
That's good.
Good, excellent, well done.
Excellent. Well done, you did it. Okay, keep coming down to the inferior angle here.
Okay.
Yeah.
Yeah.
And then you come at the bottom of the scapula right there. And
Yeah.
then we're going to stretch it. Okay, so we hit all these. So here we were right along the shoulder blade and came down like this, pressing about here, like that. So then we're going to take the muscle through its range of motion. Range of motion.
Sharon, what
Range of emotion.
about the parts where it attaches onto the ribs, like the finger-like
Yeah,
protections?
that's it.
Are
That's
those-
it. We were right in the middle. So,
Okay.
right, so we're right here. We were right here, which is the main section. But you could treat all the way onto the rib and
Yes.
get more underneath. Yeah,
Yeah.
for sure. Yeah.
Yeah,
So this
yeah.
would be that was sort of like a quick fix. Yeah.
Yeah.
Okay.
yeah.
So here you can see that she's having a little trouble getting this arm back, and that's the stretch for the anterior serratus. And then here on this side, this is the stretch for the anterior. So this side is easier for her, so she can come back a little easier.
Mhm.
So let's check you.
We didn't do this side, so
Okay,
this
so
one.
we didn't do that.
I
side.
worked
Okay.
this side. So
Okay,
this
so
is-
here,
This is
this
pretty good.
Pretty good. Yeah, pretty good. Yeah.
And we didn't
And
treat this side.
This
yet.
is a little not so good. Yeah. So she did good on one side there.
It's like
So-
you treat it is better.
So
She
you
did
put,
it!
So you put
Yeah.
the hand right over the hip, and then
Uh-huh.
you're supposed to.
Yeah, but the one way of doing it, if you watch me here,
Okay.
if you can put your elbow, your hand on your waist,
Mhm.
and then if you can push this way, you can push your elbow onto the wall,
Oh, yeah.
and then you can stretch it really good. It's a good passive stretch.
Mm-hmm.
So you can do that. We'll do it on this side. So I put my hand here, put the elbow on the wall,
Mm-hmm.
and then turn like that, and really get your elbow back.
And turn your head too. That really.
Oh,
helps,
no,
right?
no, I didn't. I
No?
just did it.
Oh, you just did it?
But it's fun
I
for
tried
the
it and it
no,
helps.
it's good for the scalene. It's good. It doesn't help the anterior. But it's good for the. But if it's good for the scalene,
Oh yeah.
it's good for the anterior serratus.
Well,
You see, so it's good.
I just tried it and it felt
Worked.
fabulous.
You liked it. You liked it.
This side.
So we just go ahead and stretch it there like that. Okay,
Wow.
great. So that's your anterior serratus.
Can I show them how I use a tiger tail on this?
Well, we were gonna do that.
Oh well, then just
Let's
do it now.
Let's do it. I brought them right here.
Yeah, you
So-
can use a tiger tail, or you can put
so-
even a tennis ball on the end of that tiger
So-
tail. That's my favorite.
Let's all use our tiger tails. So here, what I like to do for the anterior, this is again for the same muscle, the anterior serratus, right?
Right?
What we're gonna do is we're gonna put the tiger tail on the left side, okay?
Okay.
So we got it right here. Then we're gonna take the left hand, and we're gonna come like this on the side and get right up to that area,
Wow.
right in there like that, just like that. And then we're gonna do it on the other side. So you put the tiger tail here. Then I take it right here, and I come right in here, and of course, then we might as well do the latissimus dorsi right now.
Well, okay.
We might as well. Okay, so we're gonna put the lat a little bit on the stretch, and we'll see what attaches here. And
Oh,
we're gonna
yeah.
treat the latissimus dorsi just like this, and look for the trigger points right in the latissimus dorsi right here, and press on them. Press on them. So we're stretching it. Here they are, right there. That's your trigger points for your lat, right there. Let's do it on the other side. So let's get over here, and we're gonna go ahead and treat our latissimus dorsi trigger points right here. So we get
Wow.
right on them. And guess what they cause pain all the way, all over between the lower, in the lower part of the shoulder blade. And it causes it to hurt in the front of your shoulder, right on your anterior deltoid. So it causes really bad anterior deltoid pain.
Nah, I don't believe you. Let me see that.
But it's innervated by the same nerve that goes to the anterior deltoid. So that's a good. So it goes right to see where it goes.
Yes. Yep. Oh, she's right again.
C6 to C8, and so so that's a important little area there.
Yeah.
Okay, so that's our
Don't have to do
okay.
it,
So
right?
we're gonna do just a little bit more.
Okay.
Trapezius. Oh, we didn't do infraspinatus.
Yeah.
So I'm gonna do just a little bit of infraspinatus. So one way of doing infraspinatus, you get behind with your right hand towards the left side, and we can actually treat the infraspinatus like this. You roll it right like that, and you can press right onto it like this.
Mm.
This is a good one way. A lot of times when I'm walking, I take my tiger tail with me, and I treat myself while I'm walking on the lakefront. I treat different parts, and here we can treat our rhomboids, our trapezius, our iliocostalis, and like this. So we can treat our infraspinatus right here. Okay, and then let's try it on the other side. Let's go ahead, and we're going to treat our infraspinatus right here. We're walking, so we're walking. And also, it's a good tool if a dog comes along,
Oh yeah.
or people that won't bother you.
Yes, we won't call them names. We'll just call people that might want to bother you.
No one will bother you. So we're coming in through here. So I like taking it around with me. I like treating other parts. So some, just I walk around and treating myself like this using this tool, which I like quite a bit. So I think we did hit almost all the muscles. Yes, we did.
Well, now if you don't have a tiger
We
tail,
sure did. Yeah.
well, a ball against the wall is really useful.
Well, I think we should all do
I
the
think
ball.
we need to do a ball against the wall,
I think
Sharon.
we have
Wall
to.
against the wall.
Yeah,
I think we have to do
because that's the even
It's
if
the best way.
if someone is skeptical and they don't want to buy a glorious hook with knobs at the end, and they
How
don't
much do
wanna
these
buy,
cost?
Yeah, if everybody's got a tennis or a pinky ball for $1 or
Yeah,
something,
yeah, they got it, right?
and this is so effective what you can do with one of these balls. You can also put them in a sock so that you can drape them over your shoulder, and for people that have a little harder time reaching behind their back.
So this is the infraspinatus muscle
Mm-hmm.
right here, and this is we're gonna we're gonna treat it right here. It goes to your shoulder, right there. It attaches onto your humerus, and then
That's
over
right.
here.
It's right here. So the edge.
and through here. So cover
And it
this whole
comes up
area.
right here like
We'll put
this.
this on it.
That's the Empress Bonatus.
Kinda like, just like that. It's
Just like that, right
And
there.
there's the
So
spot
I
of
would
the
say it's
scapula
more
right
like this.
there.
It's here and then it spreads out like that.
Yeah,
so think
more
about
like
like
that.
that.
Yeah,
Yeah.
exactly.
So it covers that whole area like that and attaches here onto the arm.
Mhm.
So let's treat that on the wall. So we're gonna have you at kind of at a 45-degree angle to the wall. See? So you want to go ahead and try that on the wall? Yeah. So you're gonna stand at about a 40. Yeah, like that. Yeah. So about a 45. Start at the lower part. Yeah. And you're gonna go ahead and let's go up and down, and let's go side to side and little circles and look for a taut band right in that each little section of the muscle. So looking around for a nice taut band, and remember it causes pretty good pain. Now it's a muscle treating in the back of the shoulder. Guess where it causes the pain? In the front of the shoulder and between the shoulder blades. So you'll feel it between the shoulder blades and the front of the shoulder. So it's an interesting muscle. And it causes pain down the arm. Isn't that interesting?
Yeah.
So down into the hand. So it causes all kinds of pain into the arm and into the hand. So what do you think of it?
I'm finding some spots.
And remember, this is if you can't pass this test, so this is a pass if you can touch your finger to the superior angle. But it's even a pass if it's 1 inch lower or 2 inches, because it's still but it's a goal to get up here. But even coming to here is pretty good. So when we measure it, we measure from the superior angle 1 inch down, 2 inches like that. So
Shall we show them just one last thing before we break?
Yeah.
And I know we have scaling.
what's
Would using the tiger tail against the wall to get into the
okay? So let's take a look. So a really good way of using this is to put you can put something soft on the end of it. So sometimes I put this like some cloth on the end of it like this.
I swear that this one time fixed my shoulder pain.
It was so good.
It was so good.
Yeah. So I put this on the end. And so it's a really good way of treating is to use the tiger tail on the wall and like really getting your body weight right onto it. It's like that.
Oh
And you
yeah.
can get right on, this is right where you were saying, on the ribs.
Mm-hmm.
So you can get right onto those ribs and press onto it and then get a little bit further back.
Yeah.
And then you can get the arm.
That's
You can
exactly
move
what
the
I
arm.
did. Yep, I did a
You can
stretch
move
of
the
the
arm.
arm
At the same time while you're pressing on it. Yeah.
Yeah.
And you can look around. Oh, that's the tight spot. You can see.
Oh yeah.
Oh, that part not working so good. You know, so you could see.
Mine was right way up in the armpit, and
Mhm,
it just was so effective.
Oh yeah. So you can also come up into the armpit
Yep.
kind of like this
Oh yeah.
and get in there, right where the way high up in the first rib there. So get way up in there.
May just be me, but that was so awesome.
It's great to get rid of these
Oh.
awful. They're like a toothache. These referred
That's
pains.
the worst one.
Yeah.
It just was in the middle of my shoulders, would not go away.
Yeah, so this infraspinatus at the back is one of the causes a lot of front the shoulder injections because it hurts in the front.
Yeah.
Yeah, or it hurts between the shoulder blades, but it's from the shoulder or the anterior serratus.
And we're back.
Hey, we're gonna take a look at the scalenes. A great way to treat the scalenes. So we're gonna put the body support system side lying like this. We have a little bit of the hot water here to get on the shoulder and a little bit in the neck there. And we're gonna have Camille she could lay on her side with her neck right there.
I'll face it which way?
Let's face that way.
Face that way.
Put your shoulder in the little crevice.
Oh, look.
We'll put
Wow.
a little McKinsey roll on top.
That'll be nice.
Oh, she likes the idea.
Mm-hmm.
Uh-huh.
She likes
That's
everything.
comfortable.
Okay, so we're taking a look here. We see a couple of the important muscles. The
We're,
anterior
we're losing
scalene.
sound.
Oh,
Is anybody
really?
else having?
Oh,
There's you.
talk a little louder.
A
Because
little louder?
you're a distance from me, baby.
Okay. All right.
Do you hear me now?
Everybody here? No.
No? Oh, okay.
Yeah. Stephanie, will you hold this for a second?
We're gonna check it.
The sound coming there? Here, hold it for a second. Oh, yes? Okay.
Perfect.
Yes,
Good for
everybody?
me, yes.
Oh, good.
Okay.
All right, good.
All right. Sorry. It seems to be good for most people. So the weirdos that can't hear us,
They
I'm
don't
just
want to hear
kidding.
me scream.
learn to lip read or something. I'm just kidding.
Okay, so we're gonna check.
Okay.
So when we're gonna take a look at her scalenes, we're gonna look right here. We see here's the sternocleidomastoid, and you can see here's the trapezius. So the scalenes are between, so get a little closer. So the scalenes are between the sternocleidomastoid and the trapezius right here, and they attach over here onto the ribs right there. So we're going to take a look at their test. Remember their test? One of their tests is the scalene finger flexion test. You see, it's not bending too good. So let's go ahead and we're going to press into it, and we're going to see if when we treat the scalene and make it a little bit longer, can it then bend better? So will be a nice little test for us. So we're going to breathe and relax, and notice we're going to notice her breathing, and breathe and relax.
This is a famous position you'll see Sharon in.
This is the famous position.
She's got one hand feeling the finger flexion test for the scalenes.
Oh, it's coming. It's better already. Oh, so I'm right on the attachment onto the first rib, and it's starting to get better there. Yeah, right there.
The other hand is compressing and feeling the scalenes and noticing the breathing.
And coming down right onto the first rib. Yeah, so it's starting to bend nicely. So we're going to go a little bit further. We'll go a little further back. We're going to go on the middle scalene again. Here's the sternocleidomastoid. Here's the trapezius. We're going to go between the two. Get right on the middle, right on the spinous processes right there. And a little posterior to it right now. And then we're going to look at the middle scalene. And we're going to press on it, and she's going to be breathing, relaxing. Also, when she's breathing, relaxing, I always breathe and relax. And I often think of the muscle that she's using, and I'm thinking of relaxing the same muscle on me. So it's just maybe it's a good thing to do.
That's a good one.
So right on the middle scalene.
So all three scalenes are between the trapezius and
Yes,
the
they are.
SCM?
Yeah, they are. Yeah.
In that little triangle there?
They sure are. They're just all right there.
And then it generally goes that compression caused by the anterior
That's a good one.
affects the forefinger.
Yes, it does.
And then middle scalenes would be here.
Yes.
And then posterior scalenes would be the last.
It does seem to, it does maybe not true in every single case, but it
Oftentimes.
seems to be true most of the time.
Wow.
So now we're going to go to the posterior scalene. So again, it's sort of just, we're almost in the same spot.
Yeah,
And that's it right there. And you see that's the one that causes the nerve compression that causes the anterior serratus to be dysfunctional right here on the side.
Yeah. So a major cause of winging of the scapula is compression.
Of the long thoracic nerve right there between the middle and the posterior scalene. So right there, where it's all hard, right here, so you can feel the hard taut bands right there.
Yeah, that's referring up into the...
Well, if it's going up, I'm on the trapezius.
Okay.
If it's going down, I'm on the scalene. So a few fibers of the trapezius there. Yeah. So here we go. So we get right onto that. And I'm just going to move the rib cage around a little bit, the shoulder. So giving it a little bit of movement. Okay, now we're checking. Oh, we're passing that test now.
Yeah.
So you can see, but I'd like it to pass even a little bit better than that.
Yeah, it's still got that springy
So,
resistance.
yeah, oh, you saw that from a distance there. Okay, but it's like a pass, but with some tension stuff. Yeah. So we're doing a little bit more. So we're gonna stretch it and press on it. So we're taking it through a little bit of range of motion. So if I take the ribs down, it stretches it because they're attached to the ribs.
Right.
So I'm looking what sticks out when I stretch it.
This is how my relationship began with Sharon, because she was a scalene master. Sharon is a true master of the scalenes. What she's doing right now is
the
amazing.
shoulder blade is coming, the elbow is coming way down. So it's starting to come down. So it's looking good. It's looking good. She's looking really good. Let's see. So we're going to go back to the anterior scalene one more time. So I'm glad that we at least got it to pass, but I'd like it to pass with more ability for it to bend. Yeah, less stiffness. But even if a little bit of improvement is really good. So even if you had 30% improvement during a treatment, it's still very good, which it did improve a lot.
Yeah.
So at least 30% is perfect. Okay, so let's take a look at treating the anterior serratus because we're in the perfect anterior serratus position here. And it's nice to measure. So it's awfully fun to measure where you start. So you can see where am I starting. So you can measure from the oleocrine to the olecranon to the table is 11 inches. And then you can see if it improves while you're treating it.
Okay.
So remember those 9 muscles? They're attached to the inside of the shoulder blade.
Yeah.
We'll get right onto them right here. So we'll start low. I'm going to use this part of my forearm right here. I'm going to look for taut bands right there. We're going to press on it and breathe and relax.
And this is probably her second most famous mastery pose.
Now, this muscle gets into trouble when we do a lot of texting,
Yeah.
a lot of computer work on small computers, big people working on little itty-bitty, teeny-weeny computers, itty-bitty, teeny-weeny little telephones all the time.
Yeah.
So these muscles get all compressed together for that reason. So a lot of our computer mousing uses this muscle, mousing. So this is, I call this is part of mouse arm.
Mouse arm
elimination.
syndrome.
Mouse arm pain. Okay, so let's see if we improved it. Good, so it seems a little better. Just go ahead and push your elbow up towards the ceiling. And let's push it down towards the table and push it up. And let's come up a little higher. So we go into that underarm area. It goes way up high in there, yeah. That's one you told you liked.
Oh, I love that one. Yeah, what's going on there with where she's providing some resistance and range of motion is that when the muscles have had trigger points for a long time, the little myotactic units, is that what they're called?
Yeah.
Yeah, they don't fire. So she's, after compressing them, then she's getting them to fire. She's waking them up, getting full function of every single unit inside that muscle.
Okay, so here now it's coming down better.
Mm-hmm.
So again, we're about at least 30% improvement. We're about here before, so we're about here, so that's good. So push your elbow up. Let's take it up, 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 up. Keep coming, keep coming, keep coming, and let's go down, 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 down. Good, and up. Good, and down. And another muscle that we're not treating today, the pecs, also would cause you not to be able to get the elbow back.
Well, I was just going to say.
You were going to say that.
I was going to say that how I got into so much trouble with my anterior serratus is through bench press.
Yes.
Overdevelopment of the pecs, and I had trigger points in the anterior serratus. I started having shoulder problems.
Go ahead and press up your elbow and relax. And press up and relax. And
Needless
up.
to say, I don't do bench press anymore.
Oh. For that reason.
Oh no, youthful vanity is long left.
Okay, so we got a little bit more range of motion there.
Yeah.
That looks good. So it's fun to measure it again when you're as you're going along.
Measure
You
it.
could measure it, but you can measure eyeball it, but you can also go ahead and go like now it's 8.5 inches, so that's better. So it's an improvement.
All
So
right.
that's good. So it's nice to see that. Let's go ahead. Let's take a look at a couple more muscles. Let's take a look at one muscle that we didn't look at yet, which was the posterior superior serratus.
Oh yeah, this was the one that's impossible to get to because it's underneath the scapula.
So what you want to do is get the shoulder blade way forward and go where the shoulder blade used to be. Excuse me. So here it is. So here's it attaches onto the spine,
Is that your
and then
water?
onto the. Yeah, that is my water. Thank you. And we're gonna go ahead and give it a little treatment right there. Tell us what you think. How's that feel?
I don't feel anything much.
So come all the way to the top of the shoulder blade there. Now next I'm going to go inside and get my fingers underneath. So we're going to go like this and go underneath the shoulder blade. So what do you think of that spot right there?
Yeah, that's tight.
So, yeah. I'm sure you therapists already know a lot of that trick of getting underneath the scapula there.
Now we're going to do one more way of doing it.
Okay.
So if I could have you go ahead and lay as flat as you can, so a little bit more, but keep your arm there. Okay. So we're going to take a look on the, keep your shoulder, yep, right, exactly like that. We're going to go to the other side. Okay, so right here. So here you can see her shoulder blade is really pushed this way, right?
Oh yeah.
So we're going to really this is the posterior superior serratus right there. So we're going to get right on it in its most important spot, which is right here.
Wow. And you probably didn't learn that one.
When you think of that spot. So this is underneath the shoulder blade.
So she's actually getting her elbow in between the ribs and the shoulder blade.
That's right. Okay, so let's have you go ahead and stand up. Go throw your feet over the side and sit up. Okay, the way we're going to treat that, so you should learn to treat this one yourself, is we're going to use this ball, okay, and we're going to do it right over here in the wall. So we're going to go ahead and treat the posterior superior serratus. So let's come over here. Okay. So you're going to come, get this hand way across to this side, and we're going to put the ball where your shoulder blade used to be. So right there, and you're going to go from here to here to here like that. So get right on it, right there. So can you come over here? So she's this. I'll show it on Stephanie. So we're going to put this arm way across to this side, and then we're going to go from here to here. So you're rolling this on the wall from here, and you're getting underneath the shoulder blade right there. And come this way, and then underneath the shoulder blade, like this.
I think it's a little high.
So it needs to be. We'll find where the taut bands are. Get right on them like that. Yeah. Okay, so we took a look. That's the best way to treat the scale. You got to treat the scalenes that way, side lying with it all supported, and then checking to make sure that you passed the scalene finger flexion test, and also looking to see if your anterior serratus is really getting closer and closer to the spine.
Yep. Everybody,
So-
put your patients in that position this week.
Oh yes, definitely.
When you see someone in that position on a table, you know
Yes.
that is a master body worker.
That's it. That's what they're doing.
Yep.
So let's take a look at treating let's take a look at treating the latissimus dorsi. So let's take a look at that on you.
Yeah, she had that. I did.
Okay, yes.
Yeah.
Remember we had one side. This side was a little worse than the other
left,
side. So let's put the left side up. Let's treat that latissimus dorsi today.
Is this going to be the same positioning again?
Yes, but
Fabulous.
similar, but
Similar?
not exactly the same.
Okay. All right. Let's see.
Okay, so here we're going to lay them side. We're putting their arm in this little crevice.
Right.
We're putting the McKinsey roll here. We got the body support system. We got a little bit of warm water. But to treat the latissimus dorsi, we want to often put it a little bit on the stretch. So here we're going to put the bottom part of it where it's attached to the ilium here.
Wow.
This way, and we're taking the top part of it, we're attaching to the humerus that way. So we're pulling it apart, and you can see, ooh, it's a little tight on this side. Remember this side? But you did this arm didn't come up.
Right.
So we're looking, and also we checked another way, and we felt the muscle here. We saw how tight it was.
Yeah.
Oh.
What was that other way again? That was.
We just moved her. We saw,
Oh,
we're
yeah.
gonna move.
Yeah. Exactly.
Okay. So so this was one of our tests. So we're just going ahead and grabbing the latissimus dorsi and moving it around and making it a little bit longer. And we'll see if she passes the test. So here I'd like to also use so a lot of times I use the elbow, but you think, oh, it's very broad. So the forearm or the elbow. So here I'm stretching it. She's holding it down here. I'm pulling here, and now I'm going to pull back on the lat right now. So I'm stretching it in all different ways.
That's right. When you're dealing with fascia
Right,
forms
grabbing it.
adhesions in multiple planes. So try a twisting sometimes as you compress. Try rotating the other way. Try pulling one direction or the other. Find the adhesion and then work that adhesion loose.
So look at what part doesn't move, and get it to move. Yeah. So here it comes up this way. Now remember, latissimus dorsi causes pain all through here, and really a lot about right there. and it causes pain here in the front of the shoulder. So it could be the cause of a lot of front of the shoulder dysfunction and pain. So we're going to see how we're doing. So it's starting to lift up, starting to get a little looser. Okay, so let's do a little bit more of it right here. So I'm going to grab, I grab the tissue with my forearm, and I'm pulling it backwards and pressing on it at the same time and moving the fascia and the muscle. Great, so we get this is great treatment for our left lat. And here we're on it right now.
Yeah, it starts all the way down onto the top of that iliac crest.
Right there. And I'm stretching it by holding it here. And I'm grabbing it again here.
Yep. We
There
didn't
you go.
emphasize it again, but we do every class. The treating on the stretch is so critical.
Okay, let's also see how it looks on the short. So let's go ahead and let's bring it back. Let's feel it do its short and long.
Wow.
Let's feel it do its shortening and its lengthening. It's shortening, lengthening.
Wow.
Okay, let's see you do a little bit of work with it. Bring the arm close to your chest. Bring it towards your chest, your whole arm.
Oh, like
Straight down.
Straight down. Yeah, yes, good. Let me see it. Extend back and down again. Good. That's good. Great. Okay, let's see if you pass that test now. So take your time. Let's have you sit up. Let's stand up.
Gold hearts.
Okay, go. Okay, let's go ahead and sit. Let's do the overhead clamp test. Okay, and so now let's see if she's leaning a little bit to the side. So let's go ahead and we're going to have you lean to that side. Go to the right and to the left and to the right and to the left and to the right.
Yep. The range of motion tests oftentimes lead to interesting treatment postures.
Yes, it does. Okay, go ahead and move and come back and move. Good. Okay, let's look at it again. Let's take it up. Good. That's good. So that helps, looking at it when you're standing to see how it was doing. Great. So we let's check your anterior serratus on this side. Oh, pass. Good. And pass. Oh, really good. Really good. So we did quite a few of our muscles. Let's do another muscle on the stretch. Let's do the iliocostalis while we're stretching it.
Iliocostalis on the stretch.
Yes, let's try it. Let's try it. So let's look at a picture of it.
Alrighty.
So here's our iliocostalis here. So it comes along the ribs, so it attaches down here and comes all the way along the ribs and attaches onto C4, 5, 6, like in there. Okay, so let's go ahead and let's treat that. You can see it causes pain right there underneath around the shoulder blade.
So I'm guessing it extends the spine, but
Yes, it does, but it
does
also,
it also
rotate.
Yeah.
But if it attaches onto the ribs, it's going to help
Yeah,
the ribs
yeah.
come apart too.
Oh,
So it's going to be part of the rib rotation, and it's going to help with the extending and rotating. And so definitely, if it's attaching there, it's going to do that.
All right, so if
Okay,
it's,
so let's go ahead and let's treat it a little bit while we're stretching it. So I'm going to use the table a little bit while it's up higher. So let's feel your iliocostalis.
I remember her doing this to me, in fact. Well, I had such bad back pain that it was hard for me to get on and off the table, but she had me lean forward and treated it, and it worked like a
So
charm.
here we're looking for some taut bands and the iliocostalis. Okay, so is this comfortable to lean over the table? Oh, do you have any trouble leaning over the table? Okay, go ahead and lean over the table. Okay, so we're going to stretch. We're taking up the table up a little higher. Does that feel pretty good here?
yeah.
Okay, and then we're going to give it a good stretch, like that. Yeah. So it's attaching over here onto the cervical. So we're going to go ahead and give it a good stretch. So we're going to look for taut bands in it. How's that feel here?
It's a little tight.
Okay, so we're going to take a look right there. So we're going to look at the iliocostalis as it's attaching onto the ribs up in the thoracic area.
Great. At peace and happiness and tranquility.
Okay, next then I'd like to take a look at the muscle. And if you could come on this side when you're ready, Justin.
Okay.
So I like to look at the iliocostalis and feel is it doing its job. So I'd like to look right on my and see is it good? Is it doing its job? So I extend it and rotate it, and then I send it, bring your head back, and head goes to the other side, and look at is it doing its job. So you're looking for, but it's pretty good. That was the iliocostalis. Wasn't too bad. Yeah, on that side. So that's a really good way to treat our iliocostalis.
No kidding.
Yeah, super great. And then take it through that range of motion. So some nice range of motion we could do for the iliocostalis would be we can go forward and round ourselves forward like this, and for the latissimus dorsi, we're going to round forward and let's come back. But also let's do our pelvic tilts. But we have to have music for pelvic tilts.
I got it.
I'm not getting all of it.
Forward, back, forward, back. Now the pelvis just moves, but the chest stays still. Forward, back. Now side, 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 side. Forward and back, forward and back, side, side. So we're getting our lats, iliocostalis, forward and back. Let's add the chest. Head. Okay, inside, side, side, side. Now I find also you can get this motion in while you're walking. So a lot of times when I'm walking, I just go forward and back, forward and back, forward, and I get these motions in while I'm walking, from room to room or from place to place. You get those motions in, right? This is the basic motion. You got to move the pelvis. That's it. We're doing it. Okay, so we're going to take a look at the infraspinatus movement. So for that, let's go ahead. We're going to put our hand here, in here, in here. More music. Okay, and across, 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 across. You get half time or two. Double time. Okay, mouth wrap, wrap, and down, and wrap, and down, and wrap, and down, and wrap, and down, and wrap. Okay, we'll do all three. Okay, so we're gonna do touch, across, and wrap. Together. Touch, across, and wrap. Touch, across, and wrap. Touch, across, and wrap. All right? Okay, we're gonna do the scalenes. Now for the scalenes, we're gonna actually have you sit. If you can, sit down on a chair, and you're going to sit on my chair. You can sit on that chair, and you can grab right here. You're going to have your stretch your scalene to one side. Go ahead and use one hand. Stretch, stretch, stretch. Other side. Just put the weight of your hand on your head there, and just a little bit of weight. Breathe, breathe. Breathe, and other side. So you're stretching it, you're grabbing onto the bottom of your chair, and you're stretching your scalene. Other side, grab onto the bottom of your chair, get your scalene, and pull to the opposite side. And pull. So it gets an, so if you anchor the arm down, you get a little extra good stretch on that. Let's do our levator scapula, and then we're going to stretch it. Now we're going to contract it. Stretch it and contract it. Stretch it, other side. Stretch it, contract it, stretch it, contract it. Go ahead, stretch it, and contract, and stretch. Good. Super great.
More music?
Well, let's see. It's good to have music. So why is it good to have music, you guys?
Makes it more fun.
It does, right? It does. It makes it more fun. That's totally true. So what's one of the biggest underlying perpetuating factors? If scalenes is the most important muscle in pain between the shoulder blades.
Yes.
And if what is the most important underlying perpetuating factor in scalenes is paradoxical breathing. So we're gonna look at that. So everyone can sit up a little bit straight like that. So put your hand on your tummy and put one hand on your scalene. And so what you're going to do is inhale, have your tummy go out, but don't have your scalenes tighten up on you. So you're going to inhale gently, and you're going to see that your shoulders don't go up, and you're going to see that your tummy goes out, but your shoulders don't go up and your scalenes don't tighten up as you're breathing. So you're learning to do that. Let's do it on the other side. Let's do the same thing. So you're going to put one hand on the neck and one hand on the tummy, and breathe. Now, who's trying it in the field there? Is anyone noticing that they're tightening their neck while they're breathing?
What should we do if we are?
What you want to do is you want to treat the scalenes, and you want to encourage them to not contract when you're breathing. So you just, the reason your hand's there is just like biofeedback. You're getting feedback. You go, oh, I'm doing it too much. Okay, so let me see if maybe I could breathe a little less.
Yes.
That's good. Okay, so that's another way. Let's go stand up. Let's take a look at Justin. So go ahead and stand up. Okay, so let's do it also standing. Let's put one hand on our tummy and one hand on our neck.
Can you
Shoulder
step
here.
back a little bit? I can't get all that.
Okay, good. She wanted us to step back.
Yeah, I want to get the whole
Okay,
picture.
so go ahead, and you're going to press. So you're just going to press in a little bit with your fingers, and you put your now inhale, tummy goes out. Exhale, tummy goes in, and then you don't feel the neck tightening up. Inhale, tummy goes out. Now we can walk around like this. Okay, so you walk and see. Oh, so just take a little time, every day, to walk, and you can feel yourself not tightening up your neck while you're breathing, and you just feel yourself. Oh, I'm not using my neck. Good. So you learn. It's biofeedback training yourself to sitting, laying down, and standing. You train yourself every day. After a while, some people have learned to do it in only 3 weeks. They've learned it. So some people take 2 months. But no matter how long it takes, even it takes longer.
But it
Getting
is
lots of
important.
hearts.
Yeah.
You're getting lots of hearts.
Okay, good.
It is important in all three positions.
Yeah, and it's not
Yeah.
just important for the scalenes, it's
Oh,
important
well,
for
the
your
scale-
overall energy.
But it sure is. So
And
to
it-
be able to breathe
And
properly.
it forces you to use the diaphragm,
It does.
which
Yes.
gives a little massage to the organs.
That's true.
You're using.
Yeah, now Justin, he's an acupuncturist. He's one of the first, the ones that started teaching here in Chicago. And we've known each other for a long time. Okay, so that's a really important underlying perpetuating factor in mid back pain. Another muscle was the anterior serratus, and that muscle there on the side of the chest. Remember, what we get this from using computers like this, going for like this, and getting into little computers and using our cell phones, becoming like
Steering
this.
wheels even.
Steering, driving, yeah. So a lot of things that we're doing activates the anterior serratus. So it's good to get after that one. And it sneaks up on you because you hardly realize it. Here it is, but the pain's right there.
Yeah.
So here's the muscle right here, but the pain is here. See? So it's hard to understand that this muscle from doing your mousing would cause you to hurt here. You know, but it does. It's a really significant cause of that pain.
And what's another cause of that muscle having a problem? Is impingement of that long thoracic nerve by the scalenes.
That's right.
So, look at these guys. Every time you're having a problem with the anterior serratus too.
Right. That's right. That's right. Okay, so we found a lot of tests that we did today. So make sure you pass. See if you can pass all those tests. So remember, you want to be able to pass the scalene finger flexion test. You want to be able to pass this test, all these tests that we did today. The ear to your shoulder, rotation. You want to get your elbow way back, way back. You want to make sure that you're not tightening your neck when you're breathing. So you want to be able to pass all the tests and keep yourself in full range of motion, and keep yourself from reactivating all these muscles once you've got them to loosen up on you. Yeah. So today was what protocols did we do today? 12.
Yeah, 12.
We did 12, number 12 today. So this was today, mid-thoracic back pain, number 12. And these were all the muscles that we looked at. The scalenes, the latissimus dorsi, the rhomboids, levator, the serratus anterior, superior, posterior superior, I meant to say. And then also, doesn't have all of this is missing. Okay, so give me that one back again. Yeah, and this one's here, the multifidus, right here. And then the iliocostalis, the anterior serratus, the infraspinatus, and the trapezius were all the ones that cause pain between the shoulder blades. Isn't that amazing?
Yeah, well, and they cause lots of other things, so
They do.
They're great to treat. So let's say this week, your clients may not all have mid-thoracic pain, but that doesn't mean that you shouldn't lie them down in this new position that Sharon showed you, and you should evaluate the finger flexion test, evaluate the scalenes, because you're going to find good stuff. So at least put 2 or 3 people this week in that position. Practice all that stuff, and the range of motion tests.
Can I have
Start getting used to doing them every morning.
Thanks.
If you can get these posters, great, and start practicing. Do a column a day until you get really familiar with all the range of motion tests.